everybody. Good to see you. Happy Monday. I'll give you all just a second to get connected. It is a good way to start off our day today with a great program, and very excited about this particular topic. This topic actually was brought up from some of the folks in our audience, and so hopefully they're joining us today, and you guys will all enjoy this and benefit from this conversation that we're having. So before I introduce our speaker and I hand this over to him, I just want to have you guys open up your chat box, hover at the bottom of your screen and open up your chat and give us a shout out and let us know where you're joining us from. If this is your first time, we always like to find out where our folks are joining us from. My name is Anissa and I'm with PMD Alliance. I'm actually in Orlando, Florida. So I'd love to see where everyone is at. So today we're going to be talking about auditory processing and hearing issues as it relates to Parkinson's. And with us today is Dr. Robert Folmer, and he is a PhD in speech and hearing sciences from the University of California. That's where he got his PhD in San Francisco. And then he joined the Department of Otolaryngology. It's such a mouthful. I practiced this before, still got it wrong, at Oregon Health and Science University, where he maintains an appointment of associate professor. He also joined the team at the NCRAR, which I'm going to let him explain that, but he's program manager of the Joint VA and Department of Defense Hearing Loss Prevention Initiative. And he has research projects and interests that includes transcranial magnetic stimulation, TMS, which is used for the relief of tinnitus, electrophysiological assessment of auditory processing, evaluation of auditory cognitive functions of patients who have MS, as well as Parkinson's disease or traumatic brain injury. That was a lot of words, a lot of mouthful of words. So I'm going to actually pass this over to Dr. Folmer. He can do a better job of explaining a little bit of his background and then get us started in this topic today. Dr. Folmer, welcome.
Oh, thank you. I think you did a fine job. And thank you all for joining us today. I'm going to see if I can share my slides here. Let's see how the technology works. How's that? Can you see the slides?
Not yet.
Oh. Oh, okay. Can you see them now?
Perfect.
Okay, great. And you can hear me? Okay.
Sound is good, visions are good, visuals
okay.
Good.
Great, thank you.
Mm-hmm.
So yes, I'm here in Portland, Oregon, and I'm a neurophysiologist. So I study how the brain functions, and for the last 30 years or so, I've been studying how the brain, our brain processes sound. And I am here at a VA National Center for Auditory Research. And I'm going to tell you a little bit about what we've been studying with Parkinson's patients. I'll try to anyway. There we go. So these are some of the topics I'm going to cover today. I'm going to talk about some previous studies of auditory function in the Parkinson population. And I'm going to describe the studies that we've done at this National Center for Rehabilitative Auditory Research here in Portland. And I'm going to review some of the findings from the study. And then at the toward the end, I'm going to give you all some recommendations for hearing and optimizing communication. So a lot of you know about a lot of these little facts about Parkinson's disease. It affects at least 1 million people in the United States. It's the second most prevalent neurodegenerative disorder after Alzheimer's. The average age of diagnosis of Parkinson's is 60 years. And I bring that up of course, there are exceptions to that, but the average is 60 years old. And I bring that up because it is primarily a disease that affects older people. And that those are my people in auditory research, because as most people get older, we tend to acquire some hearing loss just due to aging. And then some other factors can affect hearing and communication as well. But we'll keep that in mind as we go along, that this is primarily an older population. And many of you are familiar with the motor symptoms of Parkinson's, which includes tremor and a slowness of movement and rigidity, stiffness, impaired balance. But there are also quite a few non-motor symptoms of Parkinson's, such as mood disorders, depression, anxiety, problems with cognition, such as memory, planning, attention. There's an increased risk of dementia as the disease progresses, sleep disturbance, low blood pressure when standing, and other non-motor symptoms can occur. So a lot of you also know that Parkinson's often starts with a problem in this little tiny brain area called the substantia nigra, which produces a neurotransmitter molecule called dopamine. And in this cross section of the brain, you see that the substantia nigra is this little structure here, and it's a structure in a group of structures in this area of the brain called the basal ganglia, which includes structure next door, the subthalamic nucleus, and the putamen, and the globus pallidus. And you can see those other structures listed here. Substantia nigra is down here. And as I said, the substantia nigra, the cells there produce the neurotransmitter molecule dopamine, which is then used to communicate between different brain areas, from neuron to neuron in the brain and from structure to structure, as you see here, communicating throughout the basal ganglia structures we just talked about, and also into higher areas of the brain, in the cortex, areas for movement. And normally there's a balance in the brain, in the nervous system, between excitation and inhibition. So, neurons are not firing all the time, because when we want to be still, when we don't want to move necessarily, if we're sitting still watching television, then a lot of the neurons that are responsible for movement are inhibited. So we just sit quietly. But in Parkinson's, there's a degeneration of neurons in the substantia nigra. There's a loss of that neurotransmitter dopamine, which means there's a disturbance in this balance between excitation and inhibition in the nervous system and in the brain. So that results in some of the symptoms that we see in Parkinson's, including tremor and some of the other symptoms we talked about. And I just wanted to show this diagram that indicates that even though the substantia nigra is in a, it's a relatively small area of the brain, a small region, it produces dopamine that's used as a neurotransmitter to all kinds of different brain areas. Dopamine is used throughout the central nervous system and the brain, including the auditory system that we're going to talk about today. Many of you are also familiar with treatments for Parkinson's disease, medications like L-Dopa, which have the goal of increasing the amount of dopamine available. This is a neuron releasing some dopamine into this synaptic cleft to communicate with the next neuron that receives the dopamine neurotransmitter molecules, and then it's activated, and then this chain of communication continues that way. So drugs like L-Dopa increase the amount of dopamine molecules that are available to relieve some of the symptoms of Parkinson's. In addition to drug therapies, there are also, of course, physical, occupational therapy, speech therapy, treatment of some of the other non-motor symptoms that we talked about. And there's neurosurgery that you've probably heard about or maybe even experienced, deep brain stimulation, pallidotomy, things like that. So why did we want to study auditory functions in Parkinson patients? Well, as I just explained, decreased dopamine affects many different neural networks and systems in the brain. So we wanted to investigate its effects on the auditory system. And there had been a few publications that reported that Parkinson patients exhibit some deficits in auditory processing compared to age-matched people who don't have Parkinson's disease. For instance, this is one of the studies that's studied hearing, did standard hearing tests on 20 Parkinson patients and a group of 24 age-matched control subjects. So these numbers here in hertz, that's cycles per second, these are the standard tones that are played during a hearing test. If you go in the sound booth and you put headphones on and an audiologist is in the control booth and they play tones in your ear. They play low-pitched tones, and then the frequency gets higher, so the tones get higher and higher pitched. These are the standard tones used in a standard clinical hearing test, from 250 hertz, which is very low tone, to 8,000 hertz, which is quite a high-pitched tone. And these numbers down below are how loud the tones had to be in decibels before the people heard them and press the button or raise their hand. And what this study found was that the Parkinson patients had worse hearing, which means the tones had to be louder. When they were high-pitched tones at 4,000 hertz and 8,000 hertz tones, they were significantly louder than for the control group. And if you notice down here, the mean age of these 20 Parkinson patients in this study was almost 70 years old, and the mean age of the control subjects was about 64 years old. So, and to tell you the truth, this pattern of hearing loss, high frequency hearing loss, is pretty common in people in that age range. Another group of investigators published results of what they call a gap detection test. So these green lines are supposed to indicate noise, kind of white noise, kind of a shh sound. And this red area is a very brief gap in the noise. So that's what these people were studying. They were studying how small does this gap in this ongoing noise need to be before a person can detect it, the smallest gap they can detect. And they study this because in normal speech, there are gaps between syllables, between words, between sounds that are quite subtle, but it's important to be able to identify these gaps, to hear them, so that people can understand speech well. And these people studied 19 Parkinson patients, and they compared the results of this gap detection test to a group of age-matched control subjects. And they found that the Parkinson patients couldn't hear gaps that were as brief as the ones that the control groups could hear. So the Parkinson patients, the average smallest gap in noise they could detect was about 4.5 milliseconds, which is very brief. But the control subjects could detect gaps that were shorter in duration, only 2.7 milliseconds. And even when the Parkinson patients took their medication, took L-Dopa, it didn't really improve their performance. But some Parkinson's patients who did have deep brain stimulation did improve on this task by a little bit. Here's another group that did another type of study, which is called sound lateralization. And in this study, they played sounds in this ear, and then they replaced sounds in this ear. And they were seeing how brief the difference in when the sound was played here versus when the sound was played in this ear. The briefest interval that people could detect. And the reason they were studying this is how we and our brain normally localize sounds in our environment. So if there's a sound over here in this direction, and a bell or a snapping twig or a dog barking or anything, the sound waves will hit this ear first. And a very brief time later, the sound from the object over there will hit this ear. So your brain can calculate the time difference, and it's a very brief time difference in milliseconds again, of when the sound hit this ear versus when the sound hit that ear. And your brain and your auditory system is set up so you automatically know that the sound is here, and you'll turn your attention over here because the sound hit this ear first. The sound waves hit this ear first. So they found in this study that the what they call the just noticeable difference in this timing between when sounds hit the ears was twice as long in the Parkinson patients as could be detected by the control subject. So these are all kind of indicators that Parkinson patients might have worse hearing than people of a similar age who don't have Parkinson's, and they might have trouble with things like this, which we call central auditory processing, how the brain processes sound and detects sound and gaps and things like that. There also have been studies done with EEG, electroencephalography, in which we put attach electrodes to the person's head, and we can record ongoing EEG brainwave activity. And we can also play different types of sounds and record a person's brain responses to those sounds. So we look at the brain waves that are generated in response to different sounds. And in this study, these two studies actually, they put electrodes on the people's heads, they attached them to the scalp, and then they played clicks. They play clicks at a pretty fast rate, 10 to 20 clicks per second. And they looked at what's called the auditory brainstem response, which normally looks like this in response to these clicks. So it's a very short time frame. I mean, only 5 milliseconds of time after the clicks were sounded. And these two different studies found some differences in the latency of these waves in Parkinson patients. And if you see an increased latency, an increased amount of time that these waves appear, it might indicate that there's some problem with how the brain is processing sounds, even at these early stages. However, in both of these studies, the hearing sensitivity of the participants was not mentioned. So we don't even know if their hearing was tested, because if somebody has worse hearing and they can't hear the clicks very well, then it might influence these responses of the brain waves. But that wasn't reported in these studies. So this is another type of EEG test. Again, electrodes are attached to the person's scalp, and we're recording ongoing brainwave activity. And in this case, the sounds are tones. They're not played as fast as the clicks were in the previous example. This time they're playing tones. They'll play low pitch tones like boo, boo, boo. Maybe they'll play one tone per second. And then every once in a while they'll play a higher pitch tone, a beep. So they play boo, 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 beep, boo, beep. And normally a person's brain will respond differently to the low pitch tones versus the high pitch tones. So, and what we're looking for in response to the high pitch tones, which were more unusual and kind of attract the person's attention, is this wave out at about 300 milliseconds, which is about a third of a second after the tone goes off. Your brain, without you doing anything consciously, your brain can distinguish between the high pitch tone and the low pitch tone. And the brain waves that is generated is this P300 positive voltage wave. And what different studies have shown, for instance, this one in 1997, was that the amplitude, the height of this wave, of this brain wave, was smaller in Parkinson patients compared to control patients of a similar age. So it just means that the response is not as robust in the Parkinson patients that they studied. In a couple of other studies, they found that this P300 wave was delayed a little bit in Parkinson patients, which means their auditory areas in their brain were not processing this difference between the high-pitched and low-pitched tones quite as quickly as the control subjects. And we've done studies like this also, and I'll show you the results. But I know from studying people who don't have Parkinson's or other neurological disorders that this P300 wave tends to get delayed a little bit as we get older. So as we in our brain age, then we just get a little slower in processing the difference between stimuli. However, in none of these studies was the hearing sensitivity of the participants reported. So we don't know if they tested their hearing. And I keep bringing that up because it can affect the results of these brainwave responses. So it's important to know how well a person can hear on a standard hearing test before we start drawing conclusions from these brainwave studies and other studies. This is the title of an article, and I'm showing it to you because I like the title, which is "How Do I Sound to Me? Perceived Changes in Communication in Parkinson's Disease." I think it was published by a group in England. And they concluded when they looked at Parkinson's patients and interviewed them that across the cohort of Parkinson's subjects completing the questionnaire, there was a statistically significant perception of deterioration in communication after the onset of Parkinson's disease. And they stated that the main finding of this study is that almost without exception, Parkinson's disease exercises a negative influence on communication, irrespective of age and gender. But again, even though the title of the article is "How Do I Sound to Me?" They don't mention hearing at all. They don't mention hearing ability. They don't mention hearing testing, even though the average age of the patients in their study was almost 72. So hearing loss almost always becomes an issue, is almost always present to some extent in people of that age. So we just need to keep that in mind. And we also need to keep in mind that communication is a cycle of events. Like, you have these folks over here, and the boy might be saying, why don't you turn down the TV? It's too loud. And this guy might be leaning over and saying, "What? I can't hear you." So it's a, communication is a two-way street. It's producing speech, and it's also hearing what the other person is saying. And similar over here, when people start leaning in, it means they're not hearing what this person's saying very well. So she might be asking him to speak up, or what did you say? Things like that. So we have to have this whole cycle going to complete this communication loop. We have to produce speech, produce fluent speech, but we also have to hear the feedback, not only from other people, but also from ourselves. We have to be able to hear as well as we can of what we're producing and how that sounds. So this is the study we did here in Portland. It was just a 2-year project funded by the VA Research and Development Service. And we had this whole staff of people helping us with the study. We had 35 Parkinson patients, 12 females. They didn't have any other major diseases other than Parkinson's. Their mean age was almost 67. They had Parkinson's for an average of 7 years. You might know about this Hone and Yar scale for severity of Parkinson's. For this group, it averaged a 1.7. And there's also Schwab and England scale to kind of rate the severity of the Parkinson's. And in this case, it was 86%. So in general, it means that for this group of people who volunteered for our study, that their Parkinson's disease was in the less severe range. Yeah. So then we also had control subjects. We had 35 control subjects, and they didn't have any neurological disorder, or diabetes. And their mean age was 66 years. So those were the study participants. So we did a lot of things with them. We gave them a bunch of questionnaires. We gave them some neuropsychological assessments. We tested their hearing. We gave them standard hearing tests. And we also did some more advanced and more in-depth tests of what we call central auditory processing. And I'll describe some of those tests to you. And we also did some electrophysiological assessments. We attached electrodes to their scalp and recorded their brain activity in response to different sounds. Yeah, they're also called auditory event-related potentials, voltages recorded from the scalp surface. So these are some of the questionnaires that we gave to the study participants. World Health Organization Disability Assessment Scale, HUDAS, Roman numeral 2. We also gave them medical history and hearing history questionnaires, and a questionnaire called the Hearing Handicap Inventory for adults. And these are some of the areas in the HUDAS disability assessment schedule. It's a self-rated questionnaire for communication, cognition, getting around, self-care, getting along with people, and different types of activities and participation in society rated by the person. So when we looked at the results of each of the study groups, it's not too surprising the Parkinson patients scored higher, significantly higher on this questionnaire than the control group did. Yes, statistically significant difference. And the biggest contributors to the difference in the scores, the biggest contributor was participation in society. So the Parkinson patients weren't as able to participate in activities. And The next biggest contributor was mobility, and then cognition, communication, and then household activities they weren't able to do as well. On the hearing history questionnaire, we asked, there was this question: do you have difficulty hearing the words that people are speaking? And a pretty big percentage of the Parkinson patients said, 11 of them said that they often did, and 15 said they sometimes had difficulty hearing the words people are speaking. So 26 out of 35, pretty big percentage. In the control subjects, not as many said that they often had trouble, but quite a few of them said they sometimes have trouble hearing what people are saying. And this is just an example of some of the questions that are asked on the hearing handicap inventory. Does a hearing problem cause you to use the phone less than you would like? Does it cause you to feel embarrassed when meeting new people? Does a hearing problem cause you to avoid groups of people? Does it make you irritable? Does it make you feel frustrated? Does a hearing problem cause you difficulty when you attend a party? Because of all the background noise, it's difficult to hear what people are saying. So those are the types of questions on the hearing handicap inventory. The Parkinson group scored a little higher than the control group. Statistically, it wasn't a statistically significant difference. But when we use this questionnaire to determine if the Parkinson group decided they have a severe problem, 12% of the Parkinson group said that hearing was a severe problem, versus only 6% of the control group subjects. So that's something to remember, that the Parkinson patients perceive more of a problem with their hearing. And we did just a few neuropsychological assessments. We did this one called the Ray Auditory Verbal Learning Test, which assesses a short-term memory and learning. We did this wide range achievement test, which assesses word reading ability. And we gave them the Beck Depression Inventory. And these are the results. The control subjects did a little better in this Ray Auditory Verbal Learning Test, not statistically significant difference. Again, a slight difference in this wide range achievement test, but not statistically significant. And the Parkinson patients scored a little higher in the Beck Depression Inventory. But for this group who participated in this study, at least, it wasn't statistically significant difference between the groups. This is an interesting fact that came about by accident, because people volunteered for this study. So we advertised that we were, conducting this study, and we advertised in Parkinson clinics here in Portland. And we also advertised for people who didn't have Parkinson's to compare them with. So in the control group, 20 of the 35 control participants earned bachelor's or higher degrees, which is pretty good. But in the Parkinson group, 27 out of 35, 77% of them earned bachelor's degrees or higher, professional degrees, medical degree, law degree, things like that, graduate degree. Where we're located here in Oregon, Multnomah and Washington counties, 49% of the adult population have bachelor's or higher degrees. So both of our study groups were doing better than the population at large in this area. And the Parkinson group was really quite highly educated. Maybe they were more likely to volunteer, to participate, I don't know. But this might have had some effect on the results. We'll talk about that in a minute. these are the results of the hearing test. Again, the standard hearing test. We brought the participants into a soundproof booth, and we put headphones on, and we played different tones in their ears. Again, low pitch tones, 250 hertz, and then higher and higher pitch tones, all the way up to 8,000 hertz high pitch tones. That's a standard hearing test. And this axis is decibels, how loud the tones had to be before the person heard them and pressed the button. So for these really low pitch tones, the hearing is quite similar between the groups. But when we get to this, these middle frequency tones of 1500 hertz and 2000 hertz tones, there's a significant difference in hearing sensitivity. The Parkinson's patients have a little worse hearing for these mid-range tones than compared to the control group. And these results were different than the study I mentioned earlier in the talk, published by Ilmaz and colleagues in 2009. They reported that their Parkinson patients had worse hearing at the higher frequencies, 4,000 and 8,000 hertz, compared to the control group. So why are our results different than theirs? I would say probably the biggest reason is both studies had pretty small sample sizes. And Ilmaz, their study, they only had 20 Parkinson patients, and we had 35 Parkinson patients. But I know from studying hearing sensitivity in other groups of people that to really make any, draw any broad conclusions from the results, you really need results from hundreds and maybe even thousands of people, because there's quite a bit of variability from person to person. So I think, you know, the results of our studies were different just because we had small sample sizes, and they happened to get, you know, some Parkinson patients who had worse hearing at the high frequencies, and we happened to get a few more Parkinson patients who had worse hearing in the middle frequencies. And somebody else can go out and recruit, you know, 20 or 30 patients, and they might get different results on the hearing test. But here's something even more important that came out of these hearing test results. Based on the hearing test results, 27 of the 35 Parkinson patients are considered good candidates for amplification or hearing aids to improve their hearing. And of these 27 people in the Parkinson's group who would benefit from hearing aids, only 7 used hearing aids at the time we saw them. In the control group, 19 of 35 of the control subjects are good candidates for hearing aids. And of those 19 hearing aid candidates, 11 used hearing aids. So this pretty low use of hearing aids in the Parkinson's group is unfortunately typical of the population at large. That, as I said, as most of us get older, we will develop some hearing loss due to aging, and as we continue to age, our hearing will get worse. You know, the vast majority of us. So there are a lot of people. There are millions of people out there with significant hearing loss, and this is a pretty good estimate of how many people in the population who might benefit from hearing aids actually use them. Like, yeah, 26%, which is low. And we would like to see more people use hearing aids, not because I get any money from selling hearing aids, but because it benefits the people. It helps with their communication, to hear speech and to hear environmental sounds, to hear telephone better, and television and radio and all kinds of things. So we'll talk more about this when we get to the recommendation section. So we did a bunch of these behavioral central auditory processing tests, CAP tests that we call them. There are all kinds of odd tests that we use to assess how well a person's brain is processing speech sounds. So we have the staggered sponte word test. We have the gap in noise test, which I talked about earlier. There's one called the masking level difference test, dichotic digits test, frequency pattern sequence test, words and noise tests, and a kind of an odd one called the spatial release from masking test. So we had this battery of tests that we gave people. So I'll just describe a few of these tests and the results. I won't do all of them. This is the staggered sponte word test. So in this one, we play one word in this ear. In this example, it's fruit. And then we play 2 words together through these headphones. So then we play the words juice and cup together. And then we play just the word cake in this earphone. I told you these were weird tests, but they're pretty standard tests of central auditory function, how well the brain is processing speech sounds. So the person's task is to repeat these words back, fruit, juice, cup, cake, if they can hear them and distinguish them. And then we can reverse the order too. We play them in different ears. So there's a whole list of words that we play like this. And when we look at the results, the average number of errors in this test for the Parkinson patients was about 14. And it was around the same for the control subjects. So there wasn't a big difference between our study groups. But both of these values were outside of the normal range. The normal range of outcomes for this test are 10 or fewer errors. This is for people with normal hearing or mild hearing loss. So the main reason that all of these participants got more of the words wrong was not because of Parkinson's disease necessarily. It had more to do with their age and their hearing loss. So they had some significant amount of hearing loss, and that's why they got some of the words wrong. Oh, and back to that gap in noise detection test that I told you about earlier, that people published a study where they found a difference in how small this gap could be before the participants could detect it. And in our study, there wasn't a big difference, again, between the Parkinson's group and the control group. It was hovering around 9 milliseconds was the shortest gap they could detect in ongoing noise. And again, these results are worse than the standard for this test, which is most people with normal hearing or mild hearing loss can detect gaps that are 8 milliseconds or shorter. So both of our groups did worse than that. And again, it's probably because of their age and the extent of their hearing loss. We do this dichotic digits test. Dichotic means that sounds are played in the ears simultaneously. So in this test, the 4 would be played in this ear and the 5 would be played at the same time in this headphone. So you'd hear, it's kind of like competing signals. And then soon thereafter, the 7 would be played in this ear and at the same time, the 2 would be played in this ear. So again, the person's task is to repeat the digits back that they hear. So their task is to identify these sounds, even when another sound is, a different sound is played in the opposite ear. So our groups did pretty well on this test. They did just a little worse than the people with normal hearing or mild hearing loss. For people with normal hearing or mild hearing loss, they get 90% correct or better. And our groups were close to that, and just a little worse in general, but not very different from each other. So here's a little more complicated test. So in this one, this is a person's head, and that's their nose. And they're facing a speaker, not a person, actually a stereo speaker. That's indicated by this star. So we just play a target sentence. We just play a sentence through a speaker, the person can hear it, and then they repeat the sentence back. So that's not too hard. But then we make it more difficult, and we play a target sentence, that's the star, and then we play 2 more sentences at the same time through the same speaker right in front of them. So then it's more difficult because you're trying to hear this target sentence, and then you have 2 other sentences being played simultaneously, and you try to, repeat back what the target sentence is. It's more difficult. This is like the party, the cocktail party, or the noisy bar scenario when people are talking at the same time and you're trying to hear what this one person is saying. So that's difficult. But then we change the parameters a little bit. So it's same person, same speaker in front, and we play the target sentence. But then we play these other sentences at the same time, but from a different speaker separated in space. So now this sentence is coming from a speaker over here, and we play this sentence at the same time, but from a speaker over here. And that helps actually to separate these sentences in space. Then it makes it more, a little easier for the person to hear this sentence from the speaker right in front of them. So this is another visual display of what I'm talking about. So when there's only one sentence played from the speaker right in front, like ready Charlie, go to red 5 now, that's pretty easy to hear. But when we play 3 sentences together from the same speaker, it gets all muddled. So it's difficult to identify and to hear the target sentence. But then we separate the sentences in space. We play them at the same time again, but we play this one from a speaker in front. We play this one from a speaker over here, and this one from the speaker in this direction. So that helps. They do better on this task than they do on this one. So these are the results. And going in this direction, it's worse performance, better performance in this direction. And so you see when the sentences are played all together from the speaker right in front, the Parkinson patients do worse than the control people did on that one. And when we separate the sentences in space from playing the sentences off to the side and one from the front, the controls actually did better on that compared to the other condition, and the Parkinson patients did not. They did a little worse on that test compared to the control group. So that was, of all those central auditory tests that we did, that one was the only one that was significantly different between the Parkinson group and the control group. So why was there only a difference on that one behavioral test of central auditory processing? Well, I remember I told you early on that according to the assessments we did, the progression and severity of our Parkinson's group, their Parkinson's wasn't that severe yet. Their symptoms weren't that severe. So their Parkinson's might not yet contribute to central auditory processing deficits beyond the effects of aging and hearing loss, which both groups experienced. And only the spatial release of masking test, that last one, maybe that was the only one that had sufficient sensitivity to differentiate between these populations. Okay, now we're going to put some electrodes on the people's scalps, and we're going to record brainwave activity in response to sound. We're going to do that auditory brainstem response in response to pretty fast clicks we played in the ears. And then we're going to do that P300 task where we play low pitch tones and high pitch tones. And then we're going to do, we did one dichotic digit task where we played different numbers through headphones in their ears, one in each ear simultaneously. So we'll see what the brainwave responses were like. to these sounds. So when we did the auditory brain response to those clicks, we didn't find any significant difference between the groups, which is different than other published studies. So why were our responses different? Why were our results different than the other published studies? Again, all of these studies had pretty small study populations, and people record these auditory brain responses in different ways. And the other studies did not take hearing loss into an account. They didn't report the extent of hearing loss their participants had, which can affect the results.
Hey, Dr. Folmer, I don't want to interrupt you, but I just want to let you know we have about 10 minutes left.
Okay.
So I didn't know if you were aware of that, but I just wanted to kind of give you that.
All right. Thank you.
Yes.
Yeah. So, and the other electrophysiological protocol we did was that auditory P300 called the oddball paradigm, where we played the low pitch tones, boop, boop, boop. Those are the 500 hertz tones. And then every once in a while, 20% of the time, we play a higher pitch tone, a beep, the target tone. And to help the participants stay awake in the sound booth, we told them to count the high pitch tones silently to themselves. So that was their task. So this is just, this is the cap that we put on the person's head. It's kind of like a swim cap. It has holes in it. And we inject this gel to make contact between the electrodes in the cap and the person's scalp. It's a blunt syringe. That's good. These are the different electrode positions on the head where we recorded brain activity. And this is what it looks like when they're all hooked up. Not terribly comfortable, to tell you the truth. So the cap's on their head. We also tape electrodes around their eye to keep track of eye movements. So their job is just to stay still and stay awake and count tones. So these are the brain responses to the low pitch tones, which is not the target. And as you can see, the response from the control subjects and the Parkinson's patients were just about identical. But when we look at the brain response to the target tone, the high pitch beep tones, there's a difference in timing of these P300 waves. The control subjects, on average, their P300 response was generated a little faster. So on average, it was 314 milliseconds, just a little less than a third of a second after the tone started. And the Parkinson group had a longer latency, about 381 milliseconds. So the difference is what, like 67 milliseconds, which might not seem a lot, and it's not a long length of time, but if you think about how quickly the brain normally processes stimuli and differences between stimuli, and then we react to these stimuli of all kinds, that any delay in that process is not good, really. So this is one bit of evidence that Parkinson's might interfere with the speed of processing of these auditory stimuli. And the last electrophysiological thing we did was to do this dichotic digit task, where we played digits 1, 2, 3, 4, 5, 6, just spoken digits in one ear, and we played a different digit in the other ear. So this time we told the people that their target was 4. So whenever they heard the number 4 in either ear, they should press a button, and they don't press a button if they hear the other digits. So again, this is the response of each group to the non-target digits, 1, 2, 3, 5, and 6, and they're very similar. So they're not paying as much attention to those numbers when they hear them. But the response to the target digit 4 was different. It was faster in the control group. So this time it's a negative brainwave response. So it's about 30 milliseconds faster, and it's also more robust. It's a deeper response. The amplitude is bigger for the control group compared to Parkinson's. And these are just some of the brain areas that that generate these waves. For instance, the P300 is generated by frontal cortex, oops, and so is the N200, the response to the dichotic digits. So these areas are important for learning and attention and memory functions. So here's the summary of findings from the study. In our study, the Parkinson group had worse hearing at the middle frequencies, 1500 and 2000 hertz. There were no significant differences in neuropsychological tests. And it might reflect a little less severe Parkinson's in the patients who were in our study. And the high education levels exhibited by those patients that might have some kind of a protective effect against dementia and cognitive decline. There was a worse performance by the Parkinson group on that spatial release for masking test. And there were significant differences in the electrophysiological results in the P300 and the dichotic digits tests, which might be an early indicator of some additional cognitive decline in the Parkinson's group. And as we said, a large percentage of Parkinson patients admitted they often or sometimes have trouble hearing the words people are speaking. A large percentage of the Parkinson's patients were good candidates for hearing aids, but only a small percentage of them actually used hearing aids. So here's some recommendations based on these findings. Because of the many challenges that Parkinson patients will face as their disease progresses, it's important to identify and remediate auditory dysfunction in this population as early as possible. It's important for these patients to optimize communication with their family members, caregivers, friends, clinicians, doctors, pharmacists. It's important for Parkinson's patients and everyone really to hear what these people are saying and the details about what they're saying. And it's also important for Parkinson patients who develop problems producing speech. It's important for them to be able to hear themselves, what they're producing, and also to hear the feedback from others as clearly as possible. So in a nutshell, what most people should do if they're over 60 is get a hearing test. So at least you know what your hearing is like, so you have a baseline. And if you're a candidate for hearing aids, try them. And there are a lot of different hearing aids to try. You don't have to buy the most expensive ones. They come with a 30-day trial period by federal law. If the patient might think it's difficult to manipulate hearing aids and change the batteries because they're small devices, you can certainly get help with that. And one alternative is this hearing aid made by a company called Phonak. It's called the Lyric hearing aid. And it's actually implanted deep in the person's ear canal, and it stays there for 3 or 4 months. So you don't have to manipulate it or do anything with it at all. And after 3 or more months, you go back to the audiologist and they take out the old one and they put in a new one. So it's low maintenance. Appropriate amplification can improve hearing ability, speech understanding, sound localization. It might also help to reduce the patient's risk or severity of cognitive decline, anxiety, and depression. Studies have shown that to be the case. And these are just some additional recommendations for assistive listening devices to better hear telephone, TV. People should employ effective communication strategies, which include good lighting so you can see the speaker's face, decrease the background noise, encourage speakers to speak at a reasonable rate, don't talk too fast, speak when their face can be seen clearly, keep their hands away from their face, get the listener's attention before speaking, and speak to people from a reasonable difference, 3 to 6 feet away, not from a different room, which is not usually helpful. And that's all I have. Thank you.
Awesome. So this has been really interesting. You've given us a ton of information. Unfortunately, we don't have a lot of time to answer the questions that come in. I guess I wanted to ask one quick question before we close, and you had mentioned it a little bit, but could you briefly just describe to people the impact of not being able to hear on cognition? Like, what is the correlation?
Yeah. Well, there are a lot of things going on because, you know, I see a lot of ads on TV for things like programs and over-the-counter drugs to improve, you know, cognition or to maintain your memory and all this stuff. And one thing about it, if we don't use parts of our brain, they will start to kind of deteriorate. And if we have significant hearing loss, and our auditory system, the auditory parts of our brain are not being stimulated by sound because we can't hear sounds very well, then those auditory regions will start to deteriorate. And of course, it's very important for us to hear things. It's important for us to hear what people are saying. It's important for us to hear music and television and the radio and telephone and nature sounds and all of this stuff which stimulates our brain and allows us to participate in society. And we need to react, you know, to these things, to these sounds. And many studies have shown that people with significant hearing loss who do not use amplification, who don't use hearing aids to kind of boost their auditory system, that they're more likely to experience cognitive decline and even dementia. So it's been shown that when people do use hearing aids and they get more auditory stimulation that way, that it reduces their risk of cognitive decline and dementia, and also helps them, you know, keep more engaged with other people and society in general.
Awesome. Well, Dr. Folmer, I want to thank you so much for your time and your really interesting information and your expertise in this area. I know we had a lot of questions that we didn't get to, but I really appreciate you explaining all of this to us. I thank everyone for joining us today. And if you would be willing to give Dr. Folmer this wave of gratitude that we give to thank him for his time and his expertise. Thank you so much for being a part of this today.
Oh, you're welcome. Thanks for inviting me.
Yes, and I know there was a lot of information, folks, so it was recorded, it will be put up on our website. The slides will also be available if you want to go through those and study them a little bit more, and we will have that up probably within the next day or so. So thank you very much for joining us today. We will all see you later. Take care.